Hi, we'd like to welcome today. We have Michael Campbell of the Stanly Fire Department in North Carolina, and Michael is a lieutenant, correct, Mike?
Actually, I have changed positions. It's Stanly County EMS, and I am the training officer and the deputy chief here. So I oversee all of the training. I oversee some administrative and operational things, and I'm also in charge of supervising the community paramedic division.
It's awesome, Mike. And we're going to be talking today about you're doing what? Because, a lot of people would kind of say what you're doing is a little crazy because you're partnering with syringe exchange services. So tell us a little bit about that, Mike, and what that entails and why you're doing that in your community.
Yeah, absolutely. Our community paramedic division was incorporated back in 2019 with the sole intention of combating the opiate crisis in the county. The opiate crisis here per capita is one of the worst counties in the state as far as EMS assistance goes, as far as ED visits goes, and as far as overdose deaths goes in the community. We were number 1, 2, and 3 for years, and something needed to be done, which is why we made up the community paramedic division. Partnering with syringe exchange on that is a big deal because the patients that we encounter in the scenes are also the same patients who are utilizing syringe services. So we found that correlation not long ago and realized that if we were able to work together on some things, we might be able to have a bigger impact in the community as far as overdose response goes and getting people into treatment. With syringe services and EMS, we both have peer support specialists who are similar to a AA sponsor or NA sponsor, just with a little bit more beef behind the certification. And we're lucky in the aspect that between EMS and between syringe services is we actually share one of those peer support specialists who spend some of their time on EMS and also spend some of their time over at syringe exchange. So that peer support specialist is interacting with the individuals that we serve kind of on both fronts. She's helping them at syringe services by getting them the resources they need there. And then she's also providing harm reduction efforts in the scenes if that same person was to call 911 for an opiate overdose or something related to opiate misuse or addiction. Building that relationship and earning trust has been the number one key factor in getting people to accept treatment and getting people to interact with our community paramedics and receive Suboxone, which is something that they're able to do to bridge them over into long-term treatment.
That is awesome. So several things that you said there stand out to me. But you said that with the person you're serving, the patient calls 911, it allows that person to go in. So do you have some kind of system where you get alerted if a patient that you are seeing goes ahead and calls 911 anyway? Do they alert you guys? Is there a connection between the information to track that patient?
So not necessarily, and that's just due to how dispatch and communications receives that call. They don't really put names and dates of birth out there through that. But what our community paramedics do is anytime there is an overdose dispatched or anytime someone is talking about or mentioned substance abuse or withdrawals or is feeling sick because of withdrawals, anything like that is automatically dispatched to a community paramedic. So in the field, when that happens, you'll receive a 911 ambulance to provide that immediate 911 care. But you'll also receive a community paramedic and a peer support specialist in that dispatch as well, which is how those interactions are taking place out in the field.
That's amazing. You mentioned when we were talking earlier that sometimes what the community paramedic is doing involves wound care. Can you speak a little bit to that?
The wound care is a big thing, and especially for someone who is wanting to get into treatment, whether it's inpatient treatment or even outpatient treatment, that could be a deal breaker for that patient to get into treatment. With communicable diseases and not really knowing what everybody has, a lot of treatment facilities are hesitant to accept a patient who has open wounds and open sores just for that very reason. So some of the things our CPs do is that once or twice a week, when syringe services is open and providing those services, our community paramedics actually staff that event and provide medical checks. They provide medical clearance, just general wellness checks, and wound care is part of that. So if they do have an open wound or they have something that looks like it needs to be treated, we can start providing that wound care at that time to the patient. And we can also utilize medical control and talk to the medical director of syringe services and maybe get that patient prescribed an antibiotic and try to prevent that patient from becoming an inpatient at the hospital because they ignored that wound for too long and now they got septic and have more medical complications than if we were to just treat it on scene and try to resolve that problem.
Of course, we're looking at social determinants of health and how the community paramedic can just help alleviate those and remediate those, not only just a quick fix, but remediate. And you use the word morale in there. And I thought that was very important. And to hear you talk to the audience that's listening to us a little bit more about that.
So social determinants of health are the biggest barrier for someone to get into treatment. And whether that is transportation, whether that's housing, whether it's a job, whether it's medical problems, we need to address those just as much as we need to address the addiction itself, because if someone's basic needs aren't met, getting sober is the last thing on their mind. If they don't have a warm meal to eat or a way to take a shower, they really don't care about getting sober. So using peer support is probably our biggest avenue for that. Our CPs do a lot for the medical side, but for the psychosocial side, that's where our peer support specialist comes in, and she helps navigate those resources. So if someone needs housing, she can find low cost or no cost housing for them. If someone needs transportation, she can provide transportation to and from the doctor's appointments. If they need help with jobs, she has a job assistance program that she puts people through, and also has a list of employers who are willing to hire somebody who might have a potential background issue, or who are willing to work with someone who was on Suboxone or other form of medication assisted treatment. And as far as morale goes, that really improves morale, not only for us knowing that we're doing a good service, but also for the individual served. It gives them a sense of hope that somebody cares about them and is willing to go the extra mile to see them succeed, and is trying to eliminate that stigma behind addiction that everybody who suffers from addiction is bad. And that's not the case. People have made bad choices in their lives, and some people suffering from addiction became addicted because of a prescription from a physician. Something as simple as getting a tooth pulled increases your likelihood of addiction so much more than somebody who's never had any type of narcotic prescription in their lives, and they just became unfortunate and ended up developing this addiction. Reducing that stigma and changing the stigma from a public servant's perspective is a really big thing, because for years, not only EMS, but law enforcement, fire, and any type of public servant has had a negative approach and negative outlook on patients who suffer from addiction. We got to change that from our end, and we got to be the positive change for that and start offering resources that may not have been offered in the past. If we don't, we're going to keep running into the same patient on a consistent basis. We're going to get burnout. The patient's going to get burnout, and the cycle is going to continue. So providing that peer support and meeting the patient where they're at, getting them connected with the resources that are preventing them from going into treatment, is really helping improve that. And patients are going into treatment more so now than ever, just because we're nice to them and we figure out what we can do to help make their lives better. I'll also say that that's not necessarily the job of the 911 paramedic. The 911 paramedic needs to be available to go run their calls. With the increased call volumes going on across the state and probably across the country, they don't really have time to do that. But at least recognizing that those determinants of health exist, those barriers are in place, and providing the referral to community paramedicine is more than what's ever been done in the past. And we're seeing really good results with it.
So that takes me to my next question. Do you have, and I'm going to put you a little bit on the spot here, do you have any success stories that you could share that come to your head? Like, that was a great success story of somebody that you met and was really down on their luck or going through a hard time, and through your program now they're somewhere else in their life?
We actually do. And one comes to mind as a young lady who's in her mid-30s, and she would be what you call a frequent flyer, frequent 911 utilizer for her opiate addiction. We would run her and administer Narcan 4 or 5 times a week on a regular basis. And it took quite a few months of persistence and consistency and peer support interaction for her to even be able to consider meeting with us about recovery. She had been treated so poorly in the past, not only by EMS, law enforcement, and fire, but by just the general public and the stigma behind addiction, that she didn't trust anybody. And this was a 4-month-long process of continuing trying to interact with her, peer support, trying to interact with her, seeing her at syringe exchange, then seeing her in the streets. And finally, one day she said she had had enough and she was ready to get into treatment. And this was one of those big things to where she had some underlying medical problems. She had some open wounds that needed to be addressed. And we went to work. We utilized the healthcare system locally to try to find her some low cost or no cost medical treatment. Our community paramedics were able to provide medical clearance to her at that time, so that way she could go to an inpatient detox facility. And then we started providing wound care to her as well. We would go out and help her change the bandages on her arm every day or every couple days, and really saw improvements in her well-being. Her morale started to improve just because she started feeling better. Once she left detox, she still needed some resources because detox doesn't fix you. Detox is not a cure for addiction. Still needed those resources. We were able to follow her with Suboxone after she got out of detox, continue her medical care, her medical treatment, transition or bridge her over to an outpatient substance use provider, and they took over her care after that. And this was mid to late 2020. And this same individual that we have served in that capacity is now celebrating over a year of recovery. She is a volunteer at Syringe Services and helps out with the same things that she was receiving. And she is actually almost ready to complete her peer support certification and is going to be a certified peer support specialist, and Syringe Exchange is going to hire her once she gets that certification completed. And we're just all extremely proud of her. And it was almost like a family type of deal because all of our community paramedics had a chance to interact with her over the years. Our peer support specialist had a chance to get to know her, and to see her so successful after her life had been turned upside down with addiction for so long. It's the perfect success story, right? It's the Cinderella story of how someone didn't think something could happen, and she has turned and proved everybody wrong. And she's really, really successful. Another really successful story that I'm personally proud of is that our peer support specialist who we employ, she's from Philadelphia. She's from the Kensington area, which, if you're familiar with that, is one of the worst areas in the nation for the opioid crisis. Moved down here to start a new life. We hired her as a peer support specialist, and she is almost done with her EMT training. So she started running with us and hanging out with us and decided she wanted to be more than a peer support specialist. And she's going to be one of the first people in the nation who is cross-trained as a peer support and as an EMT to be able to provide that dual role service. And I'm just incredibly proud of her as well. So you got 2 for the price on that one.
Those are amazing stories. So that speaks a lot to how your program, Mike, has grown. I've known you for a couple of years now and have seen Stanly County really grow. If you could take us briefly through how you started and where you are now, and maybe even give us a sentence or two about where you're headed in the future.
Yeah, so Stanly County, like I said earlier, was in the top of the list in the leaderboard for opiate-related calls and deaths and ER visits, healthcare costs, everything for years. It was one of those things that, just like everywhere else in the country, kind of gets swept under the rug, and it's easier to ignore it than to face it head on. The problem with that is that the people who are dying from opiate overdoses and addiction are the same people who have families and children and are contributing to the workforce. And that snowball creates a crisis for a community. Back in 2018, some funding was released from Blue Cross Blue Shield to do a study on whether peer support and pre-hospital Suboxone or out of OBOT Suboxone was going to be beneficial in getting patients into treatment. We applied for some grant funding. We were lucky enough to receive that grant funding, which was able to start our community paramedic division. We started our division with absolutely no clue of what we were doing. Our community paramedicine model was different than any other model in the nation. Most CP or MIH divisions focus on hospital discharges, frequent 911 utilization, things around those natures that we had a plan of tackling, but the opiate crisis was our number one goal. So we literally had to develop protocol, we had to develop policy, we had a lot of learning curves that we had to overcome. There were some DEA issues that came up that we didn't realize that was going to be an issue. Some legislation that had to be changed at the state level to allow paramedics to even administer Suboxone in the field. So the first 6 months to a year was just that. It was a learning curve. It was trying to figure out how we were going to do this and what we were going to do. Like I said, writing policy, writing protocol, writing SOGs. And we just slowly learned how to become successful. We went through our growing pains. We went from having 2 community paramedics that were staffed 12 hours each on an AB rotation to now we have 4 full-time community paramedics, and they provide 24-hour coverage to the community 7 days a week, 365 days a year. So we've grown exponentially. The reason why we've grown, though, is because we've been able to prove what we are doing is working. We have lowered overdose numbers in our county. We have shown that interoperability is so important, and working together to achieve goals is the only way to do it. And unfortunately, people don't just overdose between banking hours. The ones who were overdosing at 1, 2 in the morning were stuck with no resources. There was no community paramedic, no peer support. And despite our ambulance crews doing a phenomenal job with handing out brochures and giving information, there was really no way to follow up after that. So we decided to go 24 hours, started being able to provide those proactive versus reactive services 24 hours a day. And we saw a huge increase in our referrals to treatment, referrals to syringe services, referrals to other resources such as housing and food and transportation. And that's really when we started seeing a big difference in what we were doing in the community, was when we were able to provide that 24-hour coverage.
That is amazing. So you mentioned a couple of times DEA. We talked about syringe exchange. Do you worry, are there potential legal issues that somebody else that's looking to do what you're doing should just have on their radar and be aware of?
So there are. And while we do have a relationship with syringe services, there are some barriers there that prevent us from working to our fullest potential. Syringe services does more than just give out free syringes. That is part of what they do, but they also do all kinds of other harm reduction efforts. And one of those are distributing fentanyl test strips to the community. That's just something that we are not allowed to do as paramedics. There's some legal issues associated with that. And there's also just the county policies that prevent us from doing things along those lines. The good thing is having that relationship with syringe services kind of eliminates the need for us to do everything. Just like syringe services can't administer Suboxone to people in their facility, we're able to do that. So it's kind of almost like you rub my back, I'll rub yours, where we can't meet those needs, you can, and then we can meet the needs you can't. And that's what built this great relationship. Our syringe services is a 503c nonprofit, so they're not associated with county government. They're self-run, self-managed, and I think that's really important as well, because they have a little bit more freedom than we would have as government employees to do a lot of things. That doesn't mean we can't support them, though. And that doesn't mean they can't support us. And as far as eliminating stigma in the community goes, partnering with somebody who is the sole face of the reason stigma exists is eliminating stigma in real time. If we can go hand in hand and say, hey, we support each other and we work together, that helps improve the outlook of what the community has on what addiction really is. If EMS is supporting this, and EMS is providing positive outcomes from this support, the community is a lot more likely to jump on board with what we're doing just because of who EMS is. And I think that's shown tremendous strides in what we've done. The DEA regulations, we got over that, and there's really nothing that's preventing any EMS service from administering Suboxone. It's just to making sure that they have the right DEA forms filled out for what their state is requiring.
And what's in the future for Stanly County EMS as far as funding and growing the team?
So North Carolina is actually in a really good spot right now from, I don't know if you're familiar with the opiate settlement funds that are being distributed, is from the Oxycontin lawsuit. And those funds are actually getting ready to be distributed to North Carolina as early as May. And each county gets a little bit of money over a long period of time. So we're looking at getting about $4.7 million over an 18-year period. So that funding is really important for our agency, as we're requesting that a couple of our community paramedic positions be funded from those opioid settlement funds. One, to keep the cost away from the county. And if those funds are available, we want to take advantage of them and still provide the same services that we have been providing, and still keep our county able to provide the services that they're providing without having to incur additional costs. It's also providing financial services to things like syringe exchange, transportation, our MAT providers, and resources like that, to ensure that the services and the resources that are here are able to remain here in the future. We're also getting into the hospital discharges. We're hanging out with the hospitals and we're taking patients for them. We've gotten some really cool stuff, such as point of care lab testing that we can use to help diagnose and treat certain things on scene. We're doing ultrasounds for a lot of patients. So our goals for the future are to continue to advance as far as medicine will allow us to advance. We've been a very, very proactive service since we started. And we've kind of seen how far we can get away with providing medical care to patients in the field. And we've been very successful on both fronts, whether it's the opioid side or the medical side of things. And we're just looking to keep progressing and moving forward in that aspect in the future as well.
Yes, and Stanly County is very proactive in the National Association of MIH Providers as well as an agency membership. And so I thank you for your time, and I'm going to be putting your email up on the screen at the end of this, because I know there's going to be people out there, some of our members, who will definitely benefit from conversations with you, and you can share your experience with them and help them maybe not have to go through all the growing pains that you went, but help them out a little bit. So I thank you, Mike, for your time and for what you're doing in the community in Stanly County, North Carolina.
Well, thank you. And we appreciate all the support that the association has given us over the years.
All right.
Sweet.